Yeah. Okay, I know some heard you already.
Morning, guys. We're going to get started. Sam is going to first talk to us more about the structured reporting, updates on that, and then he's going to chat with us about CardioMems.
Okay, perfect. All right. So I wanted to give a quick talk on CardioMems for those of you, mostly the fellows who may not be that familiar with it. Here are my disclosures. I am a consultant for Abbott One Fire One. I have Abbott Fire One. Um, I got involved with CardioMems when Dan Jacoby was here, and we had some nice talks about this. And the issue with heart failure is a chronic condition, right? And the question is, how do we monitor or optimally assess chronic conditions? How do we manage them? Every single chronic condition that we have tools to objectively monitor their patient status, right? Whether it's a blood pressure cuff, a glucometer, a peak flow meter, an FFR, we have something. In heart failure, we don't really have much of anything, right? You've got the JVP, you've got a stethoscope, you've got your scale. None of these are particularly effective. I'm going to skip that that slide. And so all of our readily available tools aren't particularly effective at monitoring patients with heart failure. And our most accurate tools are invasive and have been difficult to obtain until now. If you look at remote monitoring programs and actual studies of remote monitoring, there's not been a single study in the United States that has shown that remote monitoring, and by that I mean, scales, whether they're Wi-Fi, Bluetooth enabled, pill bottles that have, caps on them, blood pressure cuffs, all of that stuff, having nurse call, every single randomized trial of remote monitoring in the United States has shown no difference compared to standard of care. The only trial that's been positive was a study. I think it was somewhere out of Europe. It was a small study. It showed that remote monitoring did have a positive effect on reduction of heart failure hospitalization, but not a single study in the United States has shown this at all. And you might ask about, well, what about thoracic impedance? Again, no study with thoracic impedance, because of the lag that's involved, has shown that it reduces hospitalizations. One study showed that it actually increased hospitalizations. So remote monitoring doesn't really work, but we still insist on trying it every once in a while. This is the most recent study that I found. This is the Empower RPM study. This is 2022. This is indicative of everything that we say. I mean, the curves are virtually superimposable. And obviously not statistically significant. So that brings us to the CardioMems device. That stands for Cardio Micro Electromechanical System. This was actually invented by a bioengineer, interventional cardiologist down in Atlanta back in the early 2000s. Think of it as kind of like an RFID chip. You basically ping the sensor with a radio frequency. The antennas pick up the signal. The signal that it sends back is proportional to the distance between these two gold plates here. So obviously the higher the pressure, the closer these plates are together. And then you could transform that into an actual pressure waveform signal. And these are the fidelity of the waveforms that you actually get. And they're extraordinarily high fidelity. I think the sampling rate is something like, it's over 10,000 samples. It's over 10 kilohertz. So it's over 10,000 samples per second. And the implant procedure, for those of you that have done it, you guys know it's a very simple procedure. It's really a glorified right heart cath. This is the old generation of the pill. The new one is black. It's much more sleek. It's much cooler looking, much thinner, easier to carry. The CardioMems device is probably the most well-studied interventional device it is the most well-studied interventional device in heart failure. It's got over 2,000 patients randomized and probably close to 5,000 patients, more than 5,000 patients in prospective observational studies. Going from 2011 to 2021 with the guide study. And the basic bottom line is that it leads the ability to monitor a patient leads to a 33% reduction in heart failure hospitalization across all subsets. So this includes HFrEF and HFpEF. This slide I wanted to put up here, right? So this is kind of, what is GDMT for HFpEF? Not much, right? So the SGLT2 inhibitors, which is here, empagliflozin, has a class 2A recommendation in the latest heart failure guidelines. Down here is Entresto. It has a class 2B recommendation, and so does CardioMems, has a class 2B. So remember, CardioMems isn't a treatment, it's a monitoring system, but yet the magnitude of effect is at least is actually it's bigger, right? So the hazard ratio for empagliflozin was 0.7. The hazard ratio for CardioMems was I think was 0.52. So you get a 50% reduction in heart failure hospitalizations with CardioMems, yet it's still not a class 2A, right? At least a class 2A recommendation. I don't really understand it, but that's what it is. And this finding in HFpEF and across actually all heart failure subsets is remarkably consistent. I'll show you our Yale data a little bit later. And then obviously, they got, I won't comment on how Entresto got approved for HFpEF, but these curves are not statistically significant. You could argue that there is a trend, but they were not powered to do so. But yet, because they included patients with HFmrEF, patients with ejection fractions between 35 and 45%, they actually got this to be a statistically significant study, and they got Entresto approved for patients with HFpEF. This is my favorite slide. This comes from the initial Champion trial, and I'll spend a second explaining it. So this is the heart failure event rate per year in the control group, right? So patients had about a 1.2 hospitalization rate, 1.2 hospitalizations per year if you just were randomized to standard of care. If you were randomized to, I'm sorry, that's the historical control group. No, sorry. That is the control arm of the study. In this arm of the study, you basically had a CardioMems implanted, but you weren't really allowed to use it. Right? That's the placebo arm. So the event rates were virtually superimposed. In this arm of the study, you actually used were able to use the pulmonary artery pressures from the CardioMems, but you basically had physicians following these patients, and physicians could basically override the CardioMems, and they can basically say, "Oh, you're euvolemic, you're clinically euvolemic, you're fine, your pressures may be a bit high, but I'm not going to actually change your medications." You had a significant reduction in event rates, right? That's where you get your 50%, but it's still not great. But here, in this case, if you gave your device over to a monitoring nurse, and just like a hypertension clinic, and you told the nurse, "Hey, I want you to adjust this patient's medications within certain parameters and try to normalize their PA pressures," those patients did the best. So if you went just strictly off the numbers only versus using your clinical assessment and the numbers, you actually happen to do the best in terms of heart failure hospitalizations. And this is what I'm talking about, where it's consistent across all modalities, all our heart failure types. This is in the post-approval study, 54%, 62%, 60% reductions in heart failure hospitalizations a year after implant. And just remember these numbers because our experience at Yale mirrors these. So I'm going to skip GUIDE because I don't have time. GUIDE was interesting because it expanded the indication to class 2 patients with heart failure, and you didn't have to be hospitalized anymore. You could just have an elevated BNP. The GUIDE had the misfortune of being one of 2 heart failure studies that were done during the pandemic, and the pandemic really messed things up. I can show you some of the stuff here. So this was the pre-specified overall endpoint analysis that did not reach statistical significance. It was close. There was a trend. But basically, it was because if you look at these curves and what these red and blue lines are, is basically these are the average pressures in the treatment arms and in the control arms during both pre-COVID and during COVID. And you can see what happens is during COVID, the PA pressures in both arms dropped for unclear reasons, and they were almost identical. So whether it just was because patients were eating out, whether they were taking better care of themselves or whatever, we don't really know. But this is kind of what we would expect. This is exactly what they found in Champion, where the curve separated fairly early and continued to separate as time went on, where the treatment arm had significantly lower PA pressures than in the control arm. So the FDA actually allowed Abbott to analyze the data separately, pre-COVID and post-COVID. It's the first time I've actually heard of the FDA allowing post hoc reanalysis of data like this, but because there was such a strong interaction they did allow them to do that. So this is the pre-COVID analysis where it did reach statistical significance. It was just barely statistically significant because obviously they lost quite a bit of power because they ignored all of the COVID events that occurred. But again, the heart failure hospitalizations were highly statistically significant. This was a recent meta-analysis of mortality using all of the heart failure trials. And again, as you would expect, it's a bit harder because these trials really weren't powered for mortality individually, but together they did show a 25% reduction in mortality. And again, a consistent at least 35% reduction in heart failure hospitalizations across all subsets. So this is kind of our CardioMems implants at Yale. This is kind of where we were in 2021. This is where interventional cardiology kind of took over the CardioMems implants. This is kind of where heart failure and pediatric cardiology was doing them. And then this is when Dan kind of got us involved. And it's really been a straight line going up like this. We, on average, doing about 100, across the health system, doing about 110 to 140 implants a year. We've done 511 as of today. We're implanting them all at 4 out of 5 of the delivery networks. If Dr. Canby wasn't so lazy, maybe he could do some at Westerly also. They're all followed by our disease management nurses and remote monitoring RNs, with the exception of some patients at Bridgeport and at L&M who are followed by private cardiologists, the NEMT groups, if they so choose to do so. If not, they can continue to have our nurses follow them and partner with them if they'd like to. If you look at our 1-year data, we had 444 implants implanted through November of last year, so basically a year of follow-up now. And the way we collect this data is we look at the number of admissions and number of heart failure admissions a patient had 1 year prior to their implant date. And then we look at the total number of admissions and heart failure admissions they had 1 year after their implant date to really use each patient kind of as their own control. It's not, exactly the same, but it's the best we can do. And in that case, if you look at it, you get a 31% reduction in all-cause admissions the 1 year after CardioMems implant, and you get a 52% reduction in 1 year heart failure admissions the year after implant. I'm having them rework the database a bit to try to see if we can do this, extend the data out and get, per patient year after implant to see if the effect is sustained or whether it drops off. Having a little bit of a hard time doing that because I need to censor the patient deaths. So it gets a little bit tricky because obviously I don't want to count a dead patient as having zero admissions forever. So we're trying to work through that and really trying to verify the database and find out who's actually alive or dead. That's been a real challenge in getting that sort of data out. The Epic integration has been very useful for those of you that have monitored and able to see your own patients' CardioMems numbers. That's been very, very helpful. We're one of the few hospitals across the country that have been able to do that. Hartford has also, and Abbott's basically working on making this a feature of CardioMems just integrated with Epic. These are some of kind of my take-home points from CardioMems. Who should be implanted? First question is why. I ask is why are we considering an implant? Is it because we're not sure someone's volume status is? That's probably the number one reason why we implant this thing. Patients are either morbidly obese, they've got CKD, we're never really sure, they've got intrinsic lung disease. So implanting a CardioMems really fulfills its purpose of really being an objective monitoring tool as opposed to just guessing what someone's filling pressures are. The next question is it realistic to expect a reduction in hospitalization? If the answer is no, if the patient has class 4 heart failure and they're going to be in and out of the hospital anyway, I'm not opposed to doing a CardioMems if it's really going to help the physicians manage that patient, but you shouldn't do it with the expectation that it's going to reduce their hospitalizations because it probably won't at all. Interactions with social determinants of health are very important in terms of compliance. Initially, we had a huge problem. A lot of SNFs and ECFs didn't know how to use the pillow. They didn't want to use the pillow. So we would implant these things. They would get sent to a SNF and then they'd never have a reading while they were there. They would go back to them. Well, why didn't you use it? And they said, well, we don't know how. So Abbott's been very good about engaging with them and going out there and showing the staff how to use them. So that's helped. tremendously. One area where I thought this would have been very helpful, but as it turns out, it's not really helpful at all, is for intradialytic hypotension. I thought that actually you could, use filling pressures to really gauge, what someone's filling status is, volume status is going into dialysis, and you could, tailor the therapy. It's really not. There's so much that has to do with intradialytic hypotension. The rapidity of the volume shifts is tremendous. Patients who go in with very high PA pressures, after 5 minutes after they start dialysis, their PA pressures and the systemic pressures drop like a rock. So it's really challenging. So unfortunately, not as useful for dialysis as I thought it would be. Who to implant? Not all heart failure is the same. For HFrEF patients, I tend to think it's useful for patients who are being considered for advanced therapies. The cardiac output algorithm for this device will hopefully be available second half of 2025. The study that they are doing with it has got a little bit delayed, but I think that's going to help a lot of heart failure cardiologists pick up on these patients with HFrEF who are slowly dwindling, and you can actually track their cardiac outputs with this device using a power calculation. So you can actually pick up whose cardiac outputs are going to be slowly deteriorating. Class 4 palliative patients, actually sometimes this is helpful as well, again, in kind of that management condition. Patients with LVADs, we've put a few LVAD patients in with CardioMems. I can't say it's numbers have been so few, I can't tell you if it's really useful or not. They still get admitted quite frequently, the ones that have the CardioMems. The LVAD patients, I see a very skewed population. I only see the ones that are in the hospital all the time. So the LVAD, I don't want to call them failures, but the ones that really are having a hard time. I don't see the patients who are doing well with LVADs at all. So to me, LVADs are a horrible device, but there are a lot of patients out there who are doing very well with them that I never see. So I definitely have a selection bias. For HFpEF, the really difficult patients are the patients with restrictive disease, amyloid disease, because they are so on a tightrope. Their filling pressures can change by 3 or 4 millimeters of mercury, and that's the difference between AKI and hypotension. It's really difficult. We've been trying to talk to our structural colleagues about using CardioMems more, especially in the mitral regurgitation patients, the MitraClip patients. So that's, I think, an area that we're still exploring, and hopefully Amit's here behind me will continue to work on that in the coming year or so. And the patient population I personally have found this most useful for is the typical HFpEF patient, right? So it's your patient under the age of 65 who's morbidly obese, who keeps coming into the hospital, who has probably pulmonary hypertension by their echo. They've got CKD3, hopefully they don't have CKD4 yet, and you just have a hard time managing them because they're obese and you can't see what the volume status is. The CardioMems has really been helpful in managing those patients. And not only that, we've documented several incredible success stories where either through bariatric surgery or through GLP-1 agonists, where they've lost, 75, 100, 120 pounds, and their heart failure goes away. We've proven that their pressure is normalized, they stay normal, they've come off their diuretics, and they can stay that way. So I do think that CardioMems in those patients, especially when you're working with them on weight reduction, somehow can really, really be helpful. When should we implant? It doesn't really matter so much anymore. We used to try to do all of our implants as outpatients because there is a significant contribution margin from this. If you implant as an inpatient, in general, unless they have like a 3 to 4 week hospital course, it's fairly revenue neutral because we are able to change the DRG a bit, and we are able to you don't get reimbursed for the device, but the DRG does change, so we can recoup the cost of the device. So especially in patients whose insurance still is not covering this because they keep calling it a Class 2B indication, if the patient gets admitted and you feel it's appropriate, please contact one of us, one of the implanters, and we're happy to arrange for it as an inpatient. Right heart cath is extremely useful, especially when you're uncertain about the filling their volume status, whether it's an inpatient or outpatient. We do lots of inpatient right heart caths now. I'm actually now trying to push that to the outpatient arena, where I think right heart caths as an outpatient, especially if you see pulmonary hypertension and echo and you're unsure, I think can be very, very helpful. When to implant is still, exactly especially as the outpatient is still evolving. You know, it's really hard to convince a patient to come in for a device when they're a class 2 outpatient, right? They only get shortness of breath with mild exertion, with moderate levels of exertion. But if someone gets short of breath with mild exertion, or if they've got significant pulmonary hypertension and they're feeling relatively okay, I don't have the data for this yet. I'm trying to look at some retrospective data on this, but I think those are the patients that probably would benefit from this the most. I really equate this to untreated hypertension. You know, we treat very aggressively patients who have systemic blood pressures of 160, 170, who are walking around and they say, I feel great, I have no problems. We consider that malpractice if we don't treat those patients. But yeah, patients are walking around with echoes and their PA pressures are in the mid 50s, low 60s, and they say, oh yeah, I feel fine, I can do everything I want to do. And we do nothing for them, we just ignore them. I really think that in the not too distant future, when I can get a study together and I can get Abbott to sponsor it, we're going to be able to prove that those patients actually do benefit from it. There is some data from GUIDE. I'm still kind of tabulating that, but there is a suggestion exactly that, because again, GUIDE did implant patients who were ambulatory. There is a suggestion that in those ambulatory patients that you can delay their time to first hospitalization by implanting a CardioMems earlier rather than later in the randomized arm. I'll get that data together for you guys at some point. Hopefully my next talk I can show it to you. But that's kind of the very first hint that you know, my hypothesis might be right, that patients with pulmonary hypertension or elevated BNP, in this case, are at risk for hospitalization, and the CardioMems can actually prevent that. And just remember, it's another tool. Obviously, we've had issues of sensor drift, even though less than 10% of the time has the sensor been wrong. It does happen. So if you think a patient is, you know, dry and the CardioMems is really high, or vice versa, again, don't be afraid to send them back in for a right heart cath to check the sensor. I'm going to skip all that. And then this is the current heart failure team. I tried to update this list best as I could. And then our implanters. Thank you all. You've made this a tremendous success. It's now neck and neck. It used to be, I was the #1 implanter. Samir was second, but Dr. Camby, Karthik, and Costin are nipping at Samir's heels. So Samir, you better get moving.
So Sam, can you talk a little bit about protocols? What do you typically do with the numbers? When do the
Nurses.
monitors?
Perfect. Excellent question. So it's not real. We found that it's not really, shouldn't be really a day-to-day monitoring device. So if someone's pressures were relatively normal one day or kind of at the upper, so we set a range, a goal for every patient. And they're supposed to lie on the pillow every day, kind of like an ambulatory blood pressure. And the idea is that if they're out of their range for more than 3 consecutive days, that prompts a phone call from the nurse to the patient to say, hey, your numbers have been up. How do you feel? What's going on? If they feel short of breath and the numbers are high, certainly we treat those patients. So we're working on protocols for that, but we basically, idea is to increase their diuretic regimen by 50% or 100% for 2 or 3 days, and then see if the numbers come back. And then we try to de-escalate their diuretics. What we found initially was that we were waiting too long and we would escalate their diuretics, but then we would never de-escalate. So patients would, you know, within 6 months, they'd be on just whopping doses of diuretics. So now we're actually very mindful. We try to pulse them and, you know, basically get them back to where their goal was. And that's one of the challenges we have, because right now we're better at it now, but we're still implanting patients relatively late. So if a patient gets implanted and their PA pressures are, you know, 60/30 at the time of implant, and their creatinine's already, you know, 3.5, that's a very difficult patient. I would predict that it's going to take a long time, you know, probably a year to get that patient kind of in the, you know, high 40s over low 20s range, and to hopefully keep their creatinine stable. So we try to do the best we can with those patients, but the combination of CKD4 and pulmonary hypertension is a really tough patient population to handle. But we're working on protocols like that. We're working on formalizing that, where the nurses can basically say, okay, you just double your diuretics for, you know, 2 or 3 days, and we'll follow you. The next evolution of this device is actually an app where patients will have access to their own data They'll be able to see their own data, which I think is actually a good thing. It's again very similar to home glucose monitoring. It's hard to kill yourself with a diuretic. It's actually very easy to kill yourself with insulin, but we let patients monitor their glucoses all the time. And the idea is, again, we're going to come up with algorithms and prescriptions for patients for what to do when their numbers are outside their goal for 2 or 3 days. So again, taking it even a step closer to the patient and trying to get them treated as quickly as possible.
Hey, Sam, this is Steve Fow. Nice talk. Thank you. This obviously generates a huge amount of data. What kind of, nurse to device ratio are you looking at to try to support, kind of keeping up with all the data that's accumulated?
Sure. So that's another excellent question. So patients generally fall into one of 2 categories. Either they're doing fairly well, we've kind of gotten them to goal, and they're kind of cruising along. So those patients, we do what's called managed by exception. So it's kind of this scenario where they're in range most of the time, they're not outside of their range very often, and they just need a nurse to basically check the alert system. So the system will basically just tell you, hey, like an alarm system, hey, this patient's been out of range for, a day, 2 days, 3 days, and then say, okay, you need to call this patient. So that sort of monitoring system, you could have, it varies across different health systems. There are some health systems that have 1 nurse per 500 patients in that sort of situation, because you're not having that many exceptions per day. Our system is a bit different. As I said, we're implanting still relatively late. We still have a lot of patients who are quite sick and who are out of goal. So, we try to spread the wealth a little bit. And a lot of those really difficult patients are actually managed directly by APPs or by kind of RNs who have a lot of experience with it. So it can vary. It could be, they're just mixed in with their general disease management heart failure patients. So you could be looking at a 15 or 20 to 1 patient ratio per nurse. APP is a little bit different because they're supervising a lot of things, so I can't really give you a good estimate on that. But it really depends on the patient and again, when you implant them and how they're doing. Because if they're doing fairly well, you really don't need that much staff. You're really just managing them by, by alerts, by